So I'm going to briefly go over the nomenclature change. As you heard, it is NAFLD no more, and I'll go over the rationale for that. The importance of screening high-risk populations and underscoring the fact that it's really the fibrosis that matters. And then how do we identify at-risk MASH, which is the target population both for clinical trials, and now we have the first FDA-approved therapy for this disease was just approved in March of this year. So I'll share specific data around that particular medication, Resmetirom, and then other emerging therapies in phase 3 trials. So why did we change the nomenclature? So really this disease entity was named back in 1980 by a pathologist, Ludwig, who observed that there was fat droplets in the liver associated with inflammation that looked for all purposes like alcohol-associated liver disease, but patients said, I don't drink, I don't drink. And so that's how it became a non-disease, non-alcoholic steatohepatitis. And it wasn't until 2020 that people started talking about the fact that, let's call it what it is, not what it's not. Let's not have a diagnosis of exclusion, but let's have clear inclusion criteria. And also to try to avoid stigma that comes in a name when there's alcohol or even fatty. And so one group in 2020 correctly underscored the fact that metabolic dysfunction was really central to this disease pathogenesis. However, they didn't really get kind of global consensus, number one. Number two, they didn't exclude alcohol, even some viral hepatitis. And so it wasn't really the correct process, and they didn't get rid of fatty in the name. So basically, a larger group got together, and this was a global consensus, 264 nominees from various societies, patient advocacy organizations were represented, 56 countries were represented, and it was a vigorous Delphi process, 4 rounds, over 3,000 comments. And ultimately, it was decided that we need to have a forward-looking approach to this, recognizing that an umbrella term of steatotic liver disease made sense, of which among that is MASLD, which is what you know as NAFLD, and MASH, what you know as NASH, metabolic dysfunction-associated steatohepatitis. But some of the other positive things that came from this was the creation of a new entity, MASLD, which patients who drank, historically, patients who drank alcohol, significant alcohol, have been excluded from clinical trials, they've been excluded from epidemiologic studies. And so increased alcohol intake became a new entity called MASLD. And so this is where patients have a little bit more increasing alcohol consumption. And so we're going to be studying this as a kind of a new disease. And I think there's going to be a lot of clinical trials that focus on this, because we have to recognize that patients who drink alcohol also have metabolic dysfunction, and people who have metabolic dysfunction often drink more than they admit. And then this other kind of positive about this is that the umbrella term allows for further research to better subdefine this heterogeneous population, where we might discover in our multi-omic world genomic associate, people with genotypic predisposition to certain aspects, certain types of steatotic liver disease. So really this one sets us up so that we don't have to keep doing this in the future. And these are the societies that have kind of endorsed this. And that's an old slide. It's basically, if you look in the literature now and all the publications, you'll see that it's essentially been replaced by MASLD. But the question is, okay, we've changed the name. How does that impact the interpretation of all the previously published data? Is there any impact on clinical trials? And is there any impact on qualification of biomarkers? And this is one study from France, which basically shows that, there's near 90%, 99% overlap. So if you use the new definition and you use the old definition, the population, there's 99% overlap, and therefore the data acquired for NAFLD is going to be the same as that for MASLD. If you look at NHANES data as well, 99% overlap. In a Korean population that may have a little bit more lean NAFLD, it was close to 94, 95%. So the bottom line is MASH is the new NASH, MASLD is the new NAFLD, and in fact, the FDA for therapies and for registrational trials have said, we don't care what you use parentheses, use a slash, do whatever you want. We understand which population you're talking about. So focusing now on MASLD itself, 25% of patients will have MASLD, which is defined as having at least 5% steatosis in the liver. Among those people, 20% will have the more progressive form of the disease, or MASH, which is then characterized by the steatosis plus lobular inflammation, ballooning of hepatocytes, and then various stages of fibrosis, stage 1, 2, and 3. And then among them, 5 to 20%, depending on the population you look at, will develop stage 4, which is cirrhosis, and then they're at increased risk of hepatocellular carcinoma. Patients with earlier stages of fibrosis in this disease can also develop hepatocellular carcinoma, so cirrhosis is not necessarily a requirement. Now, there's certain high-risk groups that are important to know about. So among those living with diabetes, 55 to 70% will have MASLD, 30 to 40% will have the more progressive form of the disease, and 20% will have advanced fibrosis, which is defined as at least F3 fibrosis. Among those living with obesity, approximately 15% will have advanced fibrosis. And while people living with HIV has been a little bit more understudied, they certainly have an increased amount of the progressive form, and we need a little bit more data to better understand the exact percentage of those with advanced fibrosis. Now, this is a prospective cohort where patients were undergoing, they came in for screening colonoscopy, and if they met criteria like having steatosis on an ultrasound or abnormal liver enzymes and metabolic risk factors, they were offered a liver biopsy. Hey, would you like a liver biopsy? Now, this was in Texas. And you can see about 664 said, yes, I would like a liver biopsy. And so this is just a screening population. 38% had MASLD, of whom 14% had the more progressive form. But if you look at those who are Latino, Hispanic, BMI greater than 30, those with diabetes, you can see increasing rates of both MASLD as well as MASH. And once you have a compounding risk like diabetes plus elevated BMI plus hypertension, you can see significant increases in those with MASH. Now that's Texas, and you could argue, well, that's a unique population. However, this is in France, and these are patients who were seen in diabetes clinics, and patients were sent to hepatology if they had abnormal liver enzymes or steatosis, and 330 underwent liver biopsy if their ALT was persistently over 20 in women and over 30 in men. And many of you would think, wow, that's not that abnormal. 25 is normal. But actually, it's not. Our ranges in our labs have steadily increased as our population has become more and more obese. Because as you know, in all of these labs, the reference range is based on the mean or median and the standard deviations. And so the normal ALT has marched up over the past decade. From a hepatology perspective, we think of in these numbers in terms of abnormalities in women. When they did liver biopsy in those patients, you can see that 28% had stage 3 fibrosis, 17% had F2 fibrosis. We'll get into the therapies, but the first therapy that was approved for non-cirrhotic MASH is those with F2, F3 fibrosis. So 45% of this population would have been eligible. And then 10% have cirrhosis. So you can see that looking at the prevalence among diabetics, that's particularly high. It's important to recognize that while as a hepatologist, I'm very concerned about the liver in these patients, I'm also very concerned about cardiovascular disease because cardiovascular disease is actually the #1 cause of death in these patients, followed by non-liver malignancy. So any therapeutic strategy has to also try to decrease cardiovascular risk and certainly not increase cardiovascular risk. Now, MASH is recognized to be a hepatic manifestation of metabolic syndrome, thus the name metabolic dysfunction-associated steatohepatitis. And those drivers include overnutrition, particularly dietary sugars and particularly fructose, which promotes de novo lipogenesis in the liver. At the same time, with increasing weight and insulin resistance, there is increased visceral adipose tissue, increased inflammation, resulting in lipolysis and the delivery of increased fatty acids to the liver. So not only are you making more fat in the liver, you're also delivering more to the liver. And that accumulates over time, stressing the cell. And the mitochondria, which we'll talk about in a moment, is the factory to burn that fat. But when that system is overwhelmed, you have the accumulation of lipotoxic lipids. And those lipotoxic lipids cause oxidant stress in hepatocytes, as well as a number of pro-inflammatory cytokines and cells that are infiltrating the liver, ultimately result in activation of the hepatic stellate cell, which is the primary producer of collagen or scar in the liver. And we've known for a long time that the single most important predictor of poor outcomes is fibrosis. Once you have stage 2 fibrosis, you have a 10-fold increased risk of liver-related mortality, which increases to 17-fold by the time you have F3 fibrosis and 42-fold once you have cirrhosis. We also know that patients have variable fibrosis progression. Many people, most people, it takes about 30 years to develop cirrhosis. However, some people will be rapid fibrosers and can develop cirrhosis in as little as 10 years, and some will never develop fibrosis, never develop cirrhosis. Some of you may have had experience, and now as we're screening for hepatitis C, for example, you may find an octogenarian who has hep C and has had it for 60 years because they had a blood transfusion in the Caribbean on spring break or whatever, and they don't have any scarring of the liver. So what determines fibrosis progression? So I always think of two competing processes happening in the liver. On the one hand, you have fibrogenesis. The activated stellate cell is producing type 1 collagen in response to pro-fibrogenic cytokines such as TGF-beta 1. It's initially single fibrils, single collagen fibrils, which then need to be cleaved at their N-terminal peptide to form the classic triple helical bundle, along with glycoproteins like hyaluronic acid. That N-terminal peptide can be measured in some assays for fibrogenesis, such as ProC3 and P3NP. That collagen is then extensively cross-linked by enzymes like lysyl oxidase, becoming more and more insoluble. But at the same time, we have mechanisms to degrade scar or fibrinolysis. Matrix metalloproteinases are being secreted by cells like the macrophage. C3M is one example of an MMP9 mediated degradation product of collagen 3. So these and those MMPs are inhibited by inhibitors that are known as TIMPs, tissue inhibitors of matrix metalloproteinases. So if fibrogenesis outpaces fibrinolysis, you have fibrosis accumulation. If fibrinolysis outpaces fibrogenesis, then you'll have regression. And ELF is one non-invasive assessment of liver fibrosis that is used clinically. And so you can see the biologic rationale for including P3NP, hyaluronic acid, and TIMP1. So we know that genetics play an important role in fibrosis progression rates. The two that get the most attention in the context of MASH are PNPLA3, which is a gain of function CG polymorphism that is associated with increased fibrosis progression rate in MASLD, actually also in alcohol-associated liver disease, also hepatitis C. And on the other hand, HSD17B13 is a loss of function variant that is associated with protection from MASH in individuals with fatty liver disease. And so everybody is born with their genetic predisposition. You're born a slow fibroser, you're born a rapid fibroser. And then there's a complex interplay of social determinants of health. Are you eating, drinking fructose, have access to fresh foods, or is it all processed foods? This group knows environmental factors play a critical role. What is the air that you breathe? And I'll show some data from our registry on that. And would love, this is a great opportunity for partnership and collaboration. We know that alcohol and smoking promote liver fibrosis progression, and coffee is protective for the liver. So we recommend patients drink 2 to 3 cups of black coffee a day, black only, just so that they don't, put so much cream and sugar in there that it's now a, 500-calorie drink. And so somebody who's born a slow fibroser can now become a rapid fibroser, and someone who was born a rapid fibroser could be a slow fibroser. Now, because there's been a lot of attention and now there's many guidelines that recommend screening for fibrosis in at-risk populations. This is the AGA, American Gastro Association, the Clinical Endocrinology Association, and they're all relatively similar. Essentially, you take the high-risk group, let's use type 2 diabetes as an example, and then you do a FIB-4 score. And that is a very easy calculation. I'll show it on a subsequent slide that includes age, AST, ALT, and platelet count. And that's your initial risk stratification. If you have a FIB-4 less than 1.3, we don't need to worry about you right now. We doesn't mean you're out of the woods. It's just that we can follow you longitudinally over time to look for changes. But right now, you can just be managed in your primary care setting. If you have a FIB-4 greater than 2.67, you should go see hepatology because there's a really good chance that you have advanced fibrosis. And then if you're in this intermediate zone, indeterminate zone of of 1.3 to 2.67, you need something else. What is that something else? You could get a liver stiffness assessment, such as with a FibroScan, but you can see for the endocrinology guidelines, because not everybody has access to LSM, you can get the ELF test, which is what I showed you as a non-invasive assessment of liver fibrosis. And then based on that secondary assessment, you can determine whether or not they need to go on to hepatology. I've listed the metabolic risk factors there, but I think this group probably is well aware of them. Because age is inherently part of the FIB-4, we have implemented and many have advocated for a higher FIB-4 cutoff for those over age 65 so that we don't have 70 and 80-year-olds with this indeterminate FIB-4 purely because of age. And this is the ASLD, our Liver Disease Society, but you'll see very, very similar. They're all, essentially identical. One key point about non-invasive assessments is the importance of the context of use. And so the FIB-4 test that I mentioned is really meant for primary care. So it's a general population screening because it's a low prevalence of disease. And FIB-4 has a very high negative predictive value in that population on the order of 97%. But as you move forward, it doesn't have a high positive predictive value, which is why once we come to hepatology, we are doing additional different tests that will have a higher positive predictive value. Here's the FIB-4. And for those of you who've been using it, I know we've given a talk in the World Trade Center cohort, and Andrea Branch has spoken about this. So you should know that we have a FIB-4 calculator in the EMR. So if you were to just see a patient today and put in .FIB-4, it will automatically pull in the requisite values, tell you what the FIB-4 is, and tell you what you should do. We have implemented the FIB-4 for the age over 65. So if your patient's over 65, it will automatically give you the new interpretation using 2.0 as opposed to 1.3. This is what FibroScan looks like in case you haven't seen it. You may have seen Mark Miller over there doing FibroScan, but it's quite easy. It was actually developed to measure in France to measure the stiffness of cheese, but it has now is used to measure the stiffness of the liver. It takes 5 minutes to do. Importantly, patients need to be fasting for 3 hours because the portal blood flow, as you know, the liver is supplied 75% of the blood supply comes from the portal circulation. And so after you eat, there'll be an increased blood flow through the portal vein, and that will falsely elevate the liver stiffness. And that's why we ask for fasting for 3 hours. Other things can increase the stiffness other than fibrosis. It can be increased with inflammation like active alcohol usage, cardiac congestion, biliary obstruction. But, that's just to give you an idea. This is what they look like. The CAP is a measure of the amount of steatosis or fat in the liver. So on the left, this is very minimal fat, basically normal from a steatosis standpoint. And 4.3 is a normal liver stiffness. So the machine is sending this pressure wave through the liver, and it's measuring the speed of wave propagation. A soft liver, the wave goes slowly. A stiff liver, the wave goes very fast. So it's measuring the slope, and that's the dotted line you see. And so here, this slope, 4.3. On the other hand, you look at the patient on the other panel. First, there's a lot of fat, but the stiffness is 30.8. You see the slope is like dropping like this. So that's how we measure liver stiffness. The ELF test, which I mentioned, made up those 3 factors, is also quite good. It is FDA approved for prognostication, not staging. So if you have LabCorp does it. Insurance coverage is a little bit variable, but if you have a ELF score greater than or equal to 9.8, you have a high probability of having advanced fibrosis and progression to cirrhosis. If it's greater than 11.3, you have a high risk of hepatic decompensation. We looked at our diabetes population just to say, hey, what does our population look like? We took all of the patients with diabetes who were seen by their PCP at Mount Sinai in 2023. And we said, who has the labs already? Like, we don't even have to ask anybody to draw anything, just do the math. And 90%, 45,000, already had the requisite values with no prior education to calculate the FIB-4. And when we looked at our population, 55%, 25,000 are low risk. So now we've risk stratified. We don't need to worry about them. We can repeat the FIB-4 on an annual or biannual basis to look for longitudinal changes over time, but we don't need to worry about them today. And then on the other hand, you could see about 5% have pretty advanced disease and don't know about it. This is based only on ambulatory labs because inpatient labs, you would see AST and platelets kind of being out of whack. And we've excluded patients in oncology care as well as already being seen by liver. So we're kind of at the forefront. I held a hat here in population health, and I was vice president kind of in charge of quality measures. And there are a number of quality measures specifically for those living with diabetes. As you probably know, retinopathy, nephropathy. And so we're really trying to push to make risk stratification among this group. They have the highest risk for fibrosis. We can measure the denominator very clearly. And so we can track our numerator compliance with screening over time tangibly. We know that patients are attributed in value-based contracts for diabetes. As I said, there's already existent measures for end organ damage. 28% of the Medicare population has diabetes. It's there's an NCQA diabetes recognition program. And as I showed you, FIB4 is essentially readily available with no significant incremental cost. So we are leading kind of the charge to try to get the data to support adding this as a quality measure. Diabetic hepatopathy is what we're coining it. So we launched a biobank and registry about 2 years ago. And so we enroll patients from the entire spectrum of NAFLD, no fibrosis to cirrhosis. And we have about 900 patients enrolled now, but this is a cut at 850. You can see we have 40% Hispanic, so we have great diversity. We're enrolling adolescents and pediatric patients as well. You can see the comorbidities, about 55% living with diabetes, about half with 47% with diabetes, 55% with obesity, etc. 42% have F2 to F4 fibrosis. Of course, this is a hepatology clinic now, so there's going to be a selection towards more advanced disease. And about 109 have had a liver biopsy consistent with MASH at some point, not necessarily at the time of registration. I had a master's student who was very interested in the impacts of social determinants of health on liver fibrosis. So this is just to show you some of the work that we've done, which may be relevant to this group. She looked at those in our registry, mapped the fibrosis stiffness, KPA, across the different boroughs. She looked at community deprivation index, and she also looked at air pollution. And what she found was that those with both adiposity and were in areas with high pollution had nearly double the odds of significant fibrosis, suggesting that we have to do more work on this mechanistically, and love to hear some thoughts by this group, but almost as though the adipose tissue is serving as a depot for some toxin that is promoting liver fibrosis or inflammation, adipose tissue that's resulting in increased delivery of fatty acids or pro-inflammatory cytokines. So how do we treat MASH? We always focus on lifestyle modifications first. Weight loss, exercise, diet. Exercise, even in the absence of weight loss, is associated with improvements in outcomes. As I mentioned, we discourage fructose, we encourage coffee, and the Mediterranean diet has the most data to support kind of its recommendations. And then we want to aggressively treat each comorbidity, the GLP receptor agonists or combos for obesity, treatment for diabetes. Statins are really important. Sometimes when patients have slightly elevated liver enzymes, there's hesitancy to start a statin. Don't be hesitant. It's completely safe in patients with liver disease, even being studied in those with cirrhosis. So do not fear the statin. As I mentioned, the number one cause of death in these patients is cardiovascular. So the ACCVD risk score, or I think there's a newer PREVENT score. But point is if they need a statin, start the statin. Of course, treating hypertension and sleep apnea. So I'll quickly go into thyroid hormone signaling because that's the new drug that's on the market. Hypothyroidism, along with a bunch of endocrinopathies, are associated with MASLD. And notably, the thyroid hormone beta receptor is expressed out of much more than alpha in the liver, and alpha is expressed in bone and heart. And when you think of tachycardia or osteoporosis from thyrotoxicosis, those are the alpha receptors. Now, patients who have a mutation, so there's like a human kind of genotype phenotype here, where patients who have thyroid hormone receptor beta mutation, so they're not responsive to thyroid hormone beta, they have increased liver fat compared to their unaffected family members. This is a small family in the Azores, and so you're controlling for epigenetic factors like environmental factors, the air they breathe, etc. It's the same. And even when you control for diabetes and BMI, they have increased liver steatosis. And population studies have shown associations between MASLD and overt hypothyroidism, subclinical hypothyroidism, and even low thyroid hormone in the normal range. The top-ranked gene set downregulated in human fatty liver are T3 regulated genes. And as you may recall, T4 is what is the prohormone, and in the liver, T4 is converted to the active T3 by an enzyme called diiodinase 1. Some of that T4 is converted to reverse T3 or an inactive form by DIO3. But what happens in chronic liver injury is there's upregulation of DIO3, essentially shunting to that reverse T3 or the inactive form. And so you have a relative intrahepatic hypothyroidism. And so what is the role of thyroid hormone beta in lipid metabolism? Thyroid hormone beta essentially acts like a T3 mimetic in the hepatocyte. It drives it drives fatty acid delivery to the mitochondria. It drives beta oxidation. It therefore then limits the accumulation of these toxic lipids, reducing that oxidative stress. Also, and importantly, thyroid hormone beta increases the expression of LDL receptors. So it also decreases LDL, which, as I said, if you're worried about cardiovascular disease, the drug also, and in fact, it was initially discovered being tested in patients with hereditary hyperlipidemia. So the phase 3 program it's a very large ongoing phase 3 program. Mount Sinai has been part of all of these studies, and we continue to have patients in these studies. The Maestro NAFLD was really a safety and tolerability study in 1,200 patients. Of those, 700 patients rolled over into a 52-week extension, again, looking at safety and tolerability. The registrational trial, which led to the FDA approval in March, is Maestro NASH, where the liver biopsy, and I'll show the data in a moment, was what that the FDA has accepted as a surrogate marker and for an early accelerated approval, but the study is ongoing. So it's early approval based on liver biopsy and continues to go because we have to look at outcomes. Ultimately, if the fibrosis melts, but you still have a variceal bleed, we have not accomplished anything. And then the Maestro NASH is a study in cirrhotic patients looking for those clinical outcomes. This was the New England Journal Medicine article. So those on Resmetirom, 100 milligrams, and those with 26 milligrams, there was MASH resolution, which means that the ballooning, the inflammation has subsided. But more importantly, 26% had a one-stage reduction in fibrosis. And that really was the key because no drug has shown a one-stage reduction in fibrosis to date. And then LDL, as I mentioned, it increases LDL receptors. So this is an ongoing study. We have patients in this study, but that led to the accelerated approval. You can see that for those who had elevated baseline liver enzymes, you can see a reduction in ALT, AST, GGT. Sex hormone binding globulin is actually another downstream target of thyroid hormone T3. And so therefore you see increase in SHBG, which reflects target engagement, biologic plausibility. So overall, thyroid hormone beta agonists increase the uptake of free fatty acids from the circulation, promotes, I didn't mention this actually. The other big thing that it does is it promotes mitophagy, which is the clearance of kind of tired mitochondria. And at the same time, it causes mitochondrial biogenesis, a replication of mitochondria, some fresh mitochondria to burn the fat. So getting rid of the old, replenishing the new, kind of churning that fat burning factory. So it comes in 2 doses, 80 and 100 milligrams, which is essentially weight-based. So patients less than 100 kilograms get 80. Those with greater than 100 kg get 100 milligram. I think the only important things for this, it's contraindicated in patients with on gemfibrozole or cyclosporin, but it's not approved for post-transplant, so that shouldn't really come up. What might come up is patients who are on clopidogrel or Plavix. It needs to be dose reduced to 60 milligrams. And then there is an interaction with statins. And so the max dose of rosuvastatin and simvastatin is 20 milligrams, and pravastatin and atorvastatin is 40 milligrams. But again, as I told you, it decreases LDL. The most common side effects are diarrhea and nausea. They tend to occur in the first 4 weeks, but they're generally gone by 12 weeks. Same with diarrhea, really not a big deal. So this is an expert opinion we put together to assess the kind of perfect patient for resmetirom treatment. In the green, that's kind of the Goldilocks. Not this group maybe doesn't need to be so, but you can see for the VCTE between 10 and 15 kPa, and that was really the if you look at the registrational trial, that's exactly what the patient population looked like. On the red, we do not treat patients with cirrhosis right now based on these parameters, because those it's not yet been approved in patients with cirrhosis, and that study is ongoing. There's a number of other targets in development for MASH. I'll just go over a few that might be of interest to the group. A lot of attention paid to the GLP-1s. We know that they are cardioprotective, they're renal protective, there's weight loss due to loss of appetite. So many positive beneficial effects. In the phase 2 study of semaglutide, note this is the daily dosing, not the obesity 2.4 per week. But in this study, they saw that there was MASH resolution without worsening of fibrosis, but they did not hit the fibrosis endpoint. However, it was just reported a few weeks ago at our liver meeting that their phase 3B study using the 2.4 milligram dose did achieve kind of on the same level as resmetirom, about this 14-15% delta of improvement in liver fibrosis by one stage without worsening of steatohepatitis. So we expect an early accelerated approval, probably at late 2025, early 2026 for GLP-1 as well. And then we know that there's a number of kind of twin incretins that are combined. So the dual GIP, GLP-1 receptor agonist, tirzepatide, Mounjaro, Zepbound, in their phase 2 study, they saw in the panel A MASH resolution with no worsening of fibrosis. However, they did not hit the fibrosis improvement by one stage in this phase 2 study. They are now in phase 3 study, and we anticipate, much like semaglutide, they will likely hit on that one stage improvement in liver fibrosis without worsening of MASH. Then survodutide, I should note that there are no GLP-1 receptors in the liver. They might be expressed on some infiltrating inflammatory cells, but that's important. So this twin incretin, survodutide, is a GLP-1 and a glucagon receptor agonist. Glucagon receptors are expressed on hepatocytes. So this may have also a liver-directed effect. In their, I don't know why the panel on the top, oh, there we go. Okay. In their phase 2 study, they did see MASH resolution without worsening of fibrosis. They did see a trend towards improvement in fibrosis, but that wasn't statistically significant, and we still need to see what the phase 3 study shows. Now, lanifibranor is a pan-PPAR agonist. The alpha kind of addresses the steatotic hepatocyte. The gamma impacts pro-inflammatory signaling in infiltrating macrophages. And the delta. And then the gamma impacts activated stellate cells. They showed that they had a reduction in the SAF activity score, which is similar to the MASH resolution without worsening of fibrosis in their phase 2 study after 24 weeks. On the lower panel on the left, they did see improvement of one stage of fibrosis with no worsening of NASH at the higher dose, 1200 milligram dose. They saw reduction in ALT, AST, improved glycemic indices, improved cardiovascular indices, improved markers of liver fibrosis. The one caveat with this drug, if you've ever used any of the like pioglitazone that has PPAR gamma effect, is there's weight gain. And so they did see weight gain that is, it's partly due to a shifting of where the fat is, so moving from visceral fat to peripheral, but it can be a challenge when you're talking to patients about losing weight, and then you give them a drug that causes them to gain weight. So perhaps an ideal candidate would be a diabetic who's non-obese, the lean MASLD group. There is also some potential of edema on CHF. Now, FGF1 is a very interesting target. I think you're going to hear a lot about it. It's an endogenous metabolic hormone that regulates a number of things responsible for glucose and lipid metabolism. It reduces liver fat by acting both in the liver and in the peripheral adipose tissue. It also impacts liver fibrosis because it promotes adiponectin, which is anti-fibrotic for stellate cells. The issue is that its native FGF21 has a very short half-life. And so there are drugs that have gone to prolong that half-life. So phase 2b Harmony trial, efexafermin, is a long-acting FGF21 given weekly. And you can see after 96 weeks, they saw 75% of patients, obviously small numbers, only 28 patients, but 75% of patients had a reduction in liver fibrosis by one stage compared to placebo. And they met both at the 28 and 50 milligram dose, this kind of MASH resolution without worsening of fibrosis. This is the largest delta we've seen for an anti-fibrotic effect. And so you can anticipate that this is going to be, and these trials are ongoing now. We have this study ongoing in the phase 3. Pegozafermin, now a pegylated, same idea. We're trying to just extend that half-life. I'll just point out that at the 30 milligram and 44 milligram, even now every 2 weeks, they saw that fibrosis improvement and MASH resolution. So lots happening in the FGF21 space. So when you think about the patient's continuum, those who have minimal or no fibrosis, we really want to focus on those upstream kind of targets, the GLP-1s, weight loss strategy, whether that be pharmacologic or bariatric surgery. We know bariatric surgery also works. So we want to focus on weight loss. As you move along that continuum of fibrosis, you need to start to move towards liver-directed therapy, such as Resmetirom and the number of targets that are coming out. And so the take-home points is that we have this now umbrella term of steatotic liver disease that has us set up for additional research, a multi-omic view to better categorize phenotype, genotype, patients, and better risk stratify. MASLD is the new NAFLD, MASH is the new NASH. We should be screening our at-risk populations, and the at-risk population isn't limited to diabetes, but we just feel if we could at least focus on that group, that would be a big win. Simple FIB4 followed by VCT or ELF. You should know that here at Sinai, you can just order a FibroScan in the absence of any hepatology referral. If the patient has a elevated KPA, they will automatically be scheduled and offered a hepatology evaluation. We can identify at-risk MASH, but that's more, in the hepatology scope. I mentioned that air pollution and obesity seem to small numbers and in our experience, but nevertheless, we want to explore this more. Synergistically may promote liver fibrosis. Those with F2 or greater fibrosis have a 10-fold increased risk of liver-related events. These are the patients who should be considered for the new FDA-approved therapy or be enrolled in clinical trials, and we have many. Those who have cirrhosis need liver cancer screening. That's every 6 months with ultrasound and alpha-fetoprotein. And there are a number of emerging therapeutics that are on the horizon, but we do have coffee in the meantime. And with that, I will end. and I will open it up for discussion.